Myself, Dr. Rakesh Chaudhary, third year resident from Jodhpur. I am presenting a rare case of cervical fibroid in pregnancy, which after that underwent meiosis. This is a case which came with a complaint of bleeding and with 6 months pregnancy, and cervical fibroid was there, which was diagnosed previously in 13 weeks scan. And subsequently MRI was done. She underwent, she spontaneously went into labor and delivered an IOD baby. And post delivery, MRI was done, which showed the large cervical fibroid of 14 by 15 by 22 centimeter in the anti-inferior part of the uterus. And then she was heading after getting discharged. She was subsequently discharged with the hope that that fibroid will subside after delivery. And then she came back with complaint of discharge per vaginum, and that was subsequently infested with maggots. Then subsequently hysterectomy was done, and the fibroid was removed. Introduction. Cervical fibroids are in pregnancies rarer with a prevalence of less than 1%. Fibroid size and location affect the type and degree of the patient's symptoms. Reproductive consequences with several management challenges for obstetrician. Cervical fibroids can affect the supravaginal or the vaginal portion of the cervix. There are several types of cervical fibroid and each can present differently. Supravaginal fibroids can be central, surrounding the central cervical canal, lying centrally in the pelvis, displacing the uterus superiorly. They can also be unilateral or bilateral, can be intramural or subserosal, and can be lying in the pelvis. The size of the fibroid might increase significantly during pregnancy, displacing the lower segment high up. Patient may suffer from pressure symptoms, including the urinary and GIT symptoms, and pain in the pregnancy. These are most frequently seen during the second and third trimesters of the pregnancy in women with large fibroids of more than 5 centimeter. Pedunculated cervical fibroids can arise from the endocervical canal or from the uterine cavity and protrude through the cervix. These can be very large and cause recurrent vaginal bleeding during pregnancy. Sessile cervical fibroids arising from the cervical lip of the vaginal, they arise from the cervical lip of the vaginal portion. Here we presented a rare case of cervical fibroid in pregnancy. This report is this is a 4th grade para 4 patient with bleeding and passes of clots history. She was admitted with 23 weeks and 6 days pregnancy, and this sonography done during past sonographies showed that the size was increasing with pregnancy. Her initial investigations were normal, and the graphs are showing the cervical fibroid with and her preterm vaginal delivery delivered a 500 gram fetus vaginally as breech. Subsequently, after delivery, she had complaint of urinary retention. Patient was kept catheterized, and on the day 5 of delivery, she had complaint of fever and temperature was high. Fever profile was found to be normal except that Vidal positive. So injection ceftriaxone coverage was given, and USG abdomen pelvis was done postnatally, which showed a large heterogeneous mass of 17 by 14.2 centimeter. In pelvis extending up to the epigastrium, there's a shine of uterine fibroid with bilateral hydronephrosis likely due to pelvic mass. MRI done showed a fibroid of 14 by 15 by 22 centimeter, which was displacing the uterus posterior superiorly with mild to moderate bilateral hydronephrosis due to pressure on the bilateral ureters. The patient was subsequently, after getting corrected, she was discharged, and then the patient readmitted after 4 days of discharge with complaint of discharge, and degenerated foul smelling mass was coming through the os, which signs of necrosis were there, and maggots were also seen. She was given proper antibiotics and perineal douching was done. This is the figure showing the degenerated matter that was coming at the time of admission. Reports or investigation were normal, and the mass was very much foul smelling. Per vaginal, the necrosed tissue was extracted in the OT under anesthesia. hoping that the fibroid may have prolapsed and that might be removed or can't be removed. After consulting other modalities planned for hysterectomy done, which was found to be 15 by 12 by 10 centimeter fibroid with a typical lantern on dome of St. Paul's cathedral appearance with bilateral adnex and ovaries normal and healthy. Sample, this is the operative pictures, the same, and this is the sample which was sent for histopathological examination. Discussion. Cervical fibroids in pregnancy can be challenging for obstetricians to manage, especially in our case, where the fibroid had occupied almost the entire pelvis. Cervical fibroids may cause non-cephalic presentations of the fetus, obstetrical labor, infection, pain, urinary or bowel symptoms, and bleeding per vaginum. It is important to anticipate the issues that could be faced in pregnancy and counsel patients adequately to seek for multidisciplinary help early. Most high-risk pregnancies like this should be managed in a tertiary center where blood products and interventional radiology services should be easily accessible. Women who have fibroids should be treated conservatively. Antinatal close monitoring and assessment of the size of fibroids will determine if the vaginal delivery will be suitable. It is also important to rule out malignancy if there is a solitary fibroid growing rapidly. MRI is a recommended tool to rule out any sarcomatous change and is also useful to delineate the location of the fibroid. Obstetrical labor is one of the major concern with fibroids in pregnancy. Depending on the size and anatomy of the fibroids, disease section should be advised accordingly. Advanced planning ahead of surgery will be ideal to prevent complications from arising. Hysterectomy may be considered if severe hemorrhage occurs, as the larger the fibroid, the higher the risk of bleeding may occur. Postnatally, the patient should be closely followed up to ensure that the fibroid has shrunk to its original size. However, in our case, the fibroid did not shrink and the surgery should be advised. A cervical fibroid may decrease the chance of fertility due to obstetrical labor, or if it grows in size, it can cause worsening pressure symptoms. It is therefore important for obstetrician to be aware of the complications associated and the challenges faced with the fibroids in pregnancy. Thank you.